So what I'm going to talk to you today is about preventing and managing pressure injury. Now, a lot of this I'm going to relate to the national standards, okay, and that's mainly to do with the Public Health Service. But why I talk about the national standards is because the national standards are now what will be considered best practice in Australia. So, for instance, if your facilities ever unfortunately get sued by a patient, we will be judging the best practice against the national standards. Okay? And through Gary and a number of other wound care nurses, I've been involved in a lot of legal cases as an expert witness. So this is areas, while you're not judged by the national standards if you're working in private health, you will be judged by the standards because that is what is determined to be the standards of care at this point in time. Okay? So it does relate to you with the national standards. So what's pressure injury? So pressure injury is a localised injury to the skin or underlying tissue, usually covered by bony prominence as a result of pressure, shear and or friction or a combination of these factors. And this is from the 2012 Australian Wound Management Association Pan-Pacific Guidelines, from which the national standards are heavily based. Almost word for word, the national standards are based in this consensus document. So, but they're otherwise known as bed sores, decubitus ulcers, pressure sores. So why this new term, pressure injury? Have you ever tried to do a literature search for pressure ulcers or pressure sores? You'll get some hits in pressure ulcers, some hits in pressure sores, some hits in decubitus ulcers. So you won't, if you're not using all the terms, you're not going to get all the literature to base your evidence on. So internationally, what we're trying to do now is have one term, which is pressure injury. And injury does adequately describe the damage that's caused. It is an injury. So if we have one term, hopefully from the future, when you're doing your literature research, one term's all you will be required to put into CINAHL or Medline or PubMed or whatever you're doing. So that's the reason why we're using this term pressure injury now. And hopefully, I would hope you're seeing it used a lot more. They're usually preventable. They're not always preventable. Now, when I was growing up as a young wound man, there were generally two schools of thought for pressure injury. Thou shalt never, ever, ever, ever have a pressure injury, no matter what. And the other side was, sometimes we can't prevent this no matter what we do. On this side, we didn't have much evidence. And we have some evidence for it now, which is called skin failure, which we'll talk about a little bit later. But also, some patients you could hang from the ceiling by wires and they'd still get pressure injuries because we're dealing with a lot sicker patients now. People are living longer. Okay, they increase length of stay, they cause pain and they alter the patient's body image. So deep infected pressure injury equals osteomyelitis, MRSA, amputation, sepsis and death. And we often forget that death is the end point for a lot of our patients with pressure injuries. When we're asking you to do pressure injury prevention regimes, we're not asking you just to do more work or to hurt your back or anything else. We're asking you to help prevent the loss of life because that's the end point for these pressure injuries. People die and they die on a regular basis from pressure injuries. So prevalence, around 60,000 Australian patients will suffer greater than or equal to one pressure injury. Annual accrued cost, greater than $350 million per year. Prevention traditionally has been second hourly repositioning. Who's ever done second hourly repositioning here? Put your hand up. I'm sure you have. I have. What's the evidence for it? None. We have no evidence that second hourly turning will prevent pressure injury at all. We have evidence that it helps with chest perfusion, that it can help with pain, it can help with comfort, it can help with a lot of things, but preventing pressure injuries, it doesn't. Why do we turn people every 2 hours then? Well, I want you to look at their skin. Human touch. We're nurses. We're here to care for people. It's just that human touch. Look at another wall for a couple of hours. We're doing it for a lot of other reasons. Okay. Pressure ulcers or pressure injury was cited as the underlying cause of Australian deaths in 101 cases in 97 and 98 by the media. Who thinks that's a horrific number? Anyone? Who thinks that's an accurate number? It's not an accurate number. I know 101 people who died at St George over the last 5 years of pressure injury, let alone in the whole of Australia. So why don't we have more records of deaths by pressure injury? Because on the death certificate it will be by septicemia or septic shock. The sepsis from the pressure injury is what kills the patient. And the sepsis is what goes on to the death certificate. I said this is death. Death is the end result of this. And unfortunately, as a wound care CNC of St George, I see all the patients who are going to die. Not just one ward here, one unit over there, one person. I see them all. It's not a pleasant experience, I can tell you. And explaining it to the family is not a pleasant experience either. So preventing and managing pressure injury. So this wonderful Pan-Pacific clinical guideline for the prevention and management of pressure injury was written by the Australian Wound Management Association in conjunction with the New Zealand Wound Healing Society, the Japanese Pressure Injury Society, and the Wound Healing Society of Singapore. So it's a fantastic document. It's a wonderful, and it's available as a free download from the Australian Wound Management Association website. There's a normal version and there's an adjunct version, I think they call it. Get the normal version, it's much better and it's not that much more information in it. It's a very good document, I recommend it to everybody. And from this, we get Standard 8. Standard 8 is one of 15 standards that all New South Wales health services have to comply by. If we don't pass Standard 8, or if we don't pass any of the 15 standards, the hospital fails. There's no more, you've got 12 months to get this section better. If you fail this section, you failed a lot. Okay, so there's a lot of stress around this in the past 12 months in anyone in public health because the changes were significant changes in pressure injury. So as a result, the New South Wales health policy was written by people like myself, and just about every wound care CNC south of the border and north of the border, I think, was involved in this. About 28 or 30 wound care CNCs, OTs, physios, consumer representatives were on this. So there were clinicians who helped write this policy, so it was very clinically orientated. So pressure. So what happens with pressure? You're all sitting there listening to me yabber on, getting red bums. Okay? You get vessel occlusion on your bum. You're getting hypoxia on your bum's becoming pale. Believe me, if it's not already, mine's pale blue. Okay? Takes a week of sun tanning for me to go white generally. Okay, so what do? You move, you relieve the pressure, you get a reactive hyperemia, so you get a red bum. Okay, you go from a white bum, a pale bum, to a red bum. That's not a pressure injury. Okay, your reactive hyperemia will go away after 10 or 15 minutes. Okay, but often I see a reactive hyperemia written as a stage 1 pressure injury because people haven't waited. Okay. Hypoxia resolves, resolution, hurrah, your bum's back to normal. Okay, then you're going to shift again. However, if you have persistent pressure, you get tissue ischemia, metabolic wastes accumulate, you get increased protein in the interstitial spaces, capillary leaks, tissue becomes edematous, perfusion worsens, we get a pressure ulcer or a pressure injury. Okay. It's also very much likened to reperfusion injury. Have you ever heard of crush injuries? Okay, someone gets crushed by a tractor or a car. In that time, that squash is a pressure injury, really. And that tissue is squashed and it's really squashed down hard. The body reacts to that because the tissue is dying. And you get all these oxygen-free radicals building up in the tissue. And oxygen-free radicals don't care what they debride. They don't just debride the nasty stuff, they debride everything. With people with this sort of injury, we give them a lot of potassium, which helps resolve that. But with pressure injury, you don't get that. So as soon as that resolves, you get all these oxygen-free radicals going through the tissue. And the tissue just gets eaten away by itself, by the body. Okay? How can we prevent that? Well, you really can't prevent that other than turning your patients or having them on an alternating pressure air mattress, caring for their skin. And really persistent monitoring is what we really need to do. So for us at St George, if a patient arrives to the hospital within 8 hours, we need to do a 2-part pressure injury assessment. So the 2-part pressure injury assessment is a risk assessment, such as a Waterloo. We use the Waterloo at St George. Some people use the Braden or Norton. I don't particularly care what you do, as long as you use one. And a skin inspection. A skin inspection, we cannot do one without the other. So even if you're not part of New South Wales Health, from 2012 onwards, if you're not doing skin inspection as well as a risk assessment, you are not meeting the standard of care. Standard of care is a skin assessment combined with a risk assessment tool. Okay. So we say, does the patient have a pressure injury? No. Are they at risk? No. Well, we do risk assessments once a week, or if there's a change in the patient's health status, on transfer, if a pressure injury develops, or at least weekly. Okay. Does the patient have a pressure injury? No, but they're at risk. We do a risk assessment. We use a form, which I'll show you what we're using, and we do it daily. You need a daily risk assessment. Okay. If they do have a pressure injury, we reassess them again daily. We also, in our facilities, we use an incident, some sort of incident. I'm sure you all have your own incident monitoring that you need to do, and we do a wound chart. We also do what we call an IMS sticker. IMS is our incident monitoring, but our IMS, incident monitoring in New South Wales Health, doesn't meet the national standards. So we need to provide extra information, such as, have you called me? If it's a stage 2 or above, have you called a dietitian if it's a stage 2 or above? What have you done? Was the pressure injury, was it in the hospital on arrival, or did it develop while it was in there? All this information that we're trying to gather, and we continue this on. So this is the form we use. I'll go into a little bit of detail with it, but not too much. But basically, what risk assessment scales are you using? What are you doing? So the most commonly used scales are Braden, Norton and Waterlow. Okay. However, when we look at their reliability and validity, they're there, but they're not fantastic. So there's reliability and validity for Braden, Norton, Waterlow, but what about this? Clinical judgment. That's valid. It's a valid tool. Does it mean we should use it? Yes and no. I suspect many of you are using it without the tool anyway. But the problem when you're working in an organisation with clinical judgment is that how do you replicate that? How do I replicate clinical judgment? Because your clinical judgment will be different to my clinical judgment. And if you've made a mistake with your clinical judgment, whose clinical judgment are you going to be put against? So when we're doing things like the Braden and Norton and the Waterlow in a large organisation, there's what we call inter-rater reliability. So when you're getting a score, a numerical score, we should be within 1 or 2 points of each other. Okay? So when we're within 1 or 2 points of each other, that's okay, and we can replicate that. You know, so if I got a 14 and you got a 13 or a 15 or a 16, then that's okay. But it's very hard to replicate the clinical judgment, but it is a valid tool. But when you're working in a large organisation and you're looking at what I call litigation-based nursing, nursing based on the prevention of people from suing us, and where do you think New South Wales is in the list of litigious societies around Australia, around the world, not even in Australia? Second, only to California. People are suing more often. I don't know about you, Gary, but I knock back work from lawyers asking to be an expert witness. Because it's a lot of work. It's good money. It's a lot of work. So people are suing more often. Okay, so a lot of times large facilities have to bank around that. Okay. So Waterlow. So I'll go through the Waterlow with you because it'll go into this inter-rater reliability. How's it different? So BMI, so when you're judging your BMI, do you get your patients up and measure their height? Do you weigh them exactly and then calculate the BMI? If you do, fantastic. Or do you, is this thing working? Oh, sorry, I like to wander. If you do, fantastic, but most of us go, you're a skinny, you're all right, you're a fatty. All right, let's put you up here, you'll be right. It's radar BMI. Like radar OBS. Your blood pressure's 120 on 60. Temperature 36.2. All right. If you want to cheat, if you've got a dietitian, look at their notes. They always do the BMI. That's why they've got a calculator. Or use a phone. It's always in your pocket. Mm-hmm. Continence. I shouldn't have to tell you if your patient's continent or not. Skin type. I shouldn't have to tell you about that either. Mobility, this is where we get a bit how's your father? What's the difference between apathetic and fidgety? I can move and I am. I can move but I don't want to. Restricted. What's restricted? What's restricted to you? What's restricted to me? So this is where we're going to have those differences, those points of difference, okay? Sex, definitely shouldn't have to tell you about that, or their age. The MST, the malnutrition screening tool, well, there's doubts about that at the moment going around, but it's still an all right tool. Have they lost weight? Have they deliberately lost weight? Have they not deliberately lost weight? That's pretty self-explanatory. But again here, terminal cachexia, what's that? Your patient's dying. Okay. Multiple organ failure, so they've got heart failure, renal failure, respiratory failure, they've got multiple failures going on. Single organ failure, they've just got heart failure. Peripheral vascular disease, pretty self-explanatory. Anemia, again, there's arguments around that. Is it an ongoing anemia or is it just an anemia at the time of assessment? What's going on here? Smoking, shouldn't have to tell you. Diabetes, this is a big one I find with my staff at St George. Diabetes, MS, CVA, 4 to 6. What do I give them? A 4? Do I give them a 6? So there's subjectivity here. So for me, diabetes, if someone's diabetic and they've got their sugars are well controlled, I give them a 4. If they're a 2 in the morning and a 58 at night and everywhere in between during the day, they're up and down like a yo-yo, they've already had a leg off, they've already got ulcers, I'm going to give them a 6. It's not a great way of doing yet these are valid tools. It's not a great way of doing a tool, but this is what we've got. Modus, and same with MS. My sister-in-law has just been diagnosed with MS. She's only 28. Okay, but all she's got is some tingling in her arm and leg. So I'd give her a 4. But someone who's had MS for 20 or 30 years, who's wheelchair-bound or bed-bound, we're going to give a 6. So does that make sense? And can you see how there's going to be subjectivity in there? How we're going to get that inter-rater reliability? We're going to get some scores different. Major surgery or trauma, that's self-explanatory. Medications, this is a bit of a how's your father as well. Because if you're working in aged care, your patient's got every single one of those, plus about 50 more. They rattle when they walk, half of the patients I see. So you really need to be careful about these things. So this is where we've got that inter-rater reliability, but at least I can see, if I'm assessing a patient of yours, I can see where you got your score from, okay, to see if we're doing the right thing. Skin assessment, this is our new section added to our risk assessment tools. Again, we can't do one without the other. And my staff at St George, and I think most hospitals, really sort of kicked up a stink about this, because it's a lot of extra work. But are you telling me you don't look at your patient's skin anyway? When you got them in the shower? When you're washing them? When you're helping them dress? You're not looking at their skin? I hope you are. Okay. You're not just looking for pressure injury, you're looking at a lot of other things. Okay, skin tears, all sorts of things. Funny moles. So, and we've been doing skin assessment since 2014 at St George. Our pressure injuries have dropped by 50% since we've been doing skin assessment. I've got the data, exact data there. Our pressure ulcer prevalence at St George now is 7.5%. Most tertiary referral hospitals of our size are 13 and 16%. So there's evidence for you. Doing a skin assessment will drop your pressure injuries in conjunction with your risk assessment. And when we showed this to our staff, it's amazing how much more concordant with doing the work they are, because we've got the evidence to say that they're doing it. Okay. So, but unfortunately, how do we document this? Because according to the national standards, according to the ORMA Pan-Pacific guidelines, we need to document what erythema is, what blanching response is, what localised heat is, what edema is, what induration is. Who knows what induration is? There's a couple of you. That's probably more than I expected. Most of my staff didn't know what induration was or what to look for on the skin. I must admit I had to look it up when I first saw it. And skin breakdown, that's pretty self-explanatory. So this is part of the tool we developed at St George for this, because there's no validated tool for skin inspection. So we asked our staff at St George, Sutherland Hospital and Prince of Wales, do you want to write in the notes every time you clinically document, the patient has blanching response, They have no localized heat, they have no edema, they have no induration, they have no skin breakdown, and have no erythema. Or, do you want us to do a form for you that says yes or no? Guess what they picked? The form that said yes or no. Where nurses notoriously hate forms. You bring a new form in, better paint a black cross on your door because you're going to get a whole heap of flack from the staff. Not another bloody form you're asking me to fill in. But this the staff wanted to do because it will save them work, okay? So what we do here is their blanching response. This is to all the areas on the body. Yes or no? Localised heat, yes or no? Edema, yes or no? Induration, yes or no? Skin breakdown, yes or no? Erythema, yes or no? Then we use this like an OBS chart. If there is no problem here, no further documentation is required. If there is a problem, then you go on to the clinical notes and you write, there is no blanching on the right heel. There is edema associated with this, and you write in the clinical notes. Just like if your patient had a blood pressure of 200 on 120, you're not just going to leave that on the OBS chart, are you? You're going to write in the clinical notes what you did, who you spoke to. We expect the same with this, because we wanted to minimise the work for our staff. Okay? When something needed to be done, it needed to be done. When something didn't need to be done, it didn't need to be done. Mm-hmm. So what are all these wonderful things? Blanching, push the skin, colour comes back. Okay. Localised heat, it's warm to the touch. Edema, we've just had an hour talk on lymphedema, and so if you don't know what that is, better turn your brains on. Induration, this is the hard one. My best description is a mozzie bite. Red focal centre with a spreading area of redness to the outside, and very, very dry, generally very dry, and hard. Okay. Skin breakdown, shouldn't have to tell you what that is. Erythema, redness. Okay. So we don't just do this, we also have to say what we're going to do. So we've put in for our staff, if they're less than 10, what you do. If they're at risk, what you do. High risk, what you do. Very high risk, what you do. So the staff know what to do. We also write the mattress type that we've ordered, the alternating pressure air mattress, any seating, because there's no point having this wonderful air mattress that you've got for your patient while they're sitting on a chair that's 200 years old, getting a nice pressure area on their bum while the sheets aren't getting pressure ulcers. Get them up, they need their chest perfused. That's the one, you heard that one? They'll get pneumonia, out, sit in the chair. Pressure air on your bum will kill you just as quickly as a pneumonia in your chest. So if we're going to seat them out, sometimes we get an alternating chair cushion for the chair. You can get, Huntley's out there, they've got a billion things. Rohos, all sorts of things, whatever you're going to use. But you've got to use some common sense. Sitting them out in the chair isn't 12 hours in the chair, in the one spot. Okay? We still have to move our patients. Turning regime. Like I said, whatever you really want it to be, but if someone's at high risk, I'm going to make it second hourly again because I want the skin inspection is what I want. I want people looking at the skin. We can put some cream in, not a rub. A nice just massage it in, because if you rub it, what are you going to do? You're going to damage the tissue. Okay, just massage it in, give them a massage on the bum if you like. Other mobility, are they moving? This is a new one, a big new one. Does the patient or their carer consent to the pressure injury regime? We need to document that. Because we have patients who refuse to be turned, we have patients who refuse to be on a mattress. And again, if they come back and try and sue us later, we need to have evidence. Okay. But it's also, if you're not looking on the sceptical side, it means you've fully informed your patient and their carers as to why you're doing what you're doing. We often say our patients are institutionalised, but often we're institutionalised. Do as I told you. You're going to be on this mattress. We're going to turn you. Why? Don't ask me why. We're doing it. Just doing it. Don't have time to explain this. Well, you take the time, they're going to be more... What's the difference? Here's a question for you. What's the difference between compliance and concordance? Do you know that? Compliance means, Gary, go out and play in the street. Non-compliant. Non-compliant. Who said that at the nurses' station? They're non-compliant. I've said it hundreds of times. Gary, there's some reps out there. There's some food, drinks, coffee. Go play in the street. Yeah? He's more likely to go and play in the street because I've explained it to him. That's the difference between concordance and compliance. Concordance means you've been fully educated as to why we want to do something. This can be with compression, this can be with anything. And if Gary as an adult then still chooses not to, it's his decision. But he's been fully educated. Would you rather be compliant or concordant yourself as a patient? You'd rather be concordant, wouldn't you? So when you're yelling out at the desk, they're not bloody compliant. What do they come here for? Think about it. Who's compliant? So this is my most favourite piece of literature in the universe because it's older than me, and there's no way in hell you'd get the ethics for this today. No way. I met the lady who did this literature. She's a lovely lady, this research. 1961. This one. In a 500 residential aged care facility in the UK, 500 beds. On a 7-hour night duty. 90% of patients who were turned less than 10 times developed a pressure injury. Those who were turned greater than 20 times were less likely to develop a pressure injury, but many still did. Only those who were turned greater than 54 times did not develop a pressure injury. You turn me 54 times on a night duty, I'll slap you. Okay? What's your back going to be like at the end of the shift? Any managers here? Watch the compo forms come flying in and you have no staff. You can't do it. Can't do it. Okay? We've known for greater than 5 decades. This is not a new concept. That alternating pressure every 5 minutes will prevent cell death and pressure injury development. Not a new concept. And it's continually been proven again and again and again in the literature. That's why we need our alternating pressure air mattresses. And if you're not using them, you put yourselves and your patients at risk. Okay? Prevention, we need to prevent the patient against the external forces of pressure, friction and shear. We need to eliminate shear and friction, produce heel pressure, promote activity and mobilisation, use an appropriate support surface and instigate an appropriate turning schedule. It's funny enough, I was in Japan with Gary for the World Union of Wound Healing Societies conference about shear and friction. Because how often do you grab the patient by the shoulders and zip them up the bed? And this little Japanese man came up and he was giving a talk. I think he was 80 in the shade, this chap. He was one of the main speakers. And he said, when you turn someone on their side, from their back to their side, you need to lift their skin off the surface of the mattress and actually plop them down. Because when you keep them on the mattress, their skin comes along with it and shears, and that's why you get a pressure injury often perpendicular to the bone, not right on the bone. I'm thinking, mate, you're not looking after half the patients I look after. We're not looking after little Japanese people here. I had a guy come in at 220 kegs into St George the other day. I'm not going to lift him up without a little crane or something, let alone to get him over on his side. But we often underestimate shear and friction. So he made his point well, that we don't just pull and zip people along, and that's why your slide sheets are good and your pelican belts and things like that, to get people off that skin that we've moved across, okay? So it's not just to zip up the bed, it's a pulling of the tissue across and putting pressure on a thinner amount of tissue. So our alternating pressure devices distribute total body weight over the largest surface, zero pressure to a part of the body every few minutes around the clock. So for us, if they've got a water low of 15 plus, we put them on a high risk mattress. If they're a water low of 20 plus, we put them on a very high risk mattress. There are different cell cycles. It doesn't really matter if it's a 2-cell or a 3-cell or a 4-cell. What it matters to your patient, do you wonder why your patients don't like the mattress sometimes? What shape does this do when we're going up and down? It's a sine wave. Anyone get seasick here? Your patients can get seasick on the mattresses. You're looking at me like I'm an idiot. It's true. They can get seasick on these mattresses. That's sometimes why they don't like them. We give them a bit of Stemetel, they get over that, and they tend to be fine. Because you're on a sine wave, 24 hours around the clock. So until their body gets used to it, they can get seasick. Okay. Seating and heel devices. Again, if they're going to sit out for a long time, we need to use these. Patient leaflets, there's a lot of leaflets available. The Clinical Excellence Commission have a number of free leaflets available that you can give to patients and their family in a number of key languages, all of the below there. Now, before I go here, how many stages of pressure injury are there? 4, 6, 28? I feel like I'm playing bingo. Do you play bingo in here too? Or housey. Sorry, we can't call it bingo, it's housey. It's housey. Bingo's trademarked. That's my grandmother used to go to housey all the time. So there are 6 stages now. Okay? 2 additional stages. They're not called stage 5 or 6. We'll go into that. But I must say, if you're getting new graduate nurses coming through, they're still not teaching this in university. Okay, they've not updated to this new model. Or TAFE if you're getting enrolled nurses as well. Okay. So we've got a stage 1, which is non-blanchable erythema, intact skin, non-blanchable erythema. So when we go to blanch it, after 20 minutes, that redness doesn't go away and it doesn't blanch. Okay. Darker pigmented skin can be particularly hard to assess because it shows up as a blue or purple hue. And the Americans have struggled with the African American population for years looking for this. Maybe painful, maybe warm, but like I said, it can be difficult to assess. So a nice, see, it's a dull red. It's not a bright in-your-face red, and it's focal to a bony prominence. Not to be mistaken for incontinence-associated dermatitis. This bright red bum you're looking at, sorry, lots of bums in my presentations, is incontinence-associated dermatitis. And incontinence-associated dermatitis is a completely different monster. It's an inflammatory process associated with urine or feces on the skin. The big hint, if you're not sure, your patient's incontinent. Okay? And it's generally shot up the front as well as shooting up the back. Generally, when I see them this big, staff have put too much zinc cream on. When you put a lot of zinc cream on and then put the incontinence pad on, what happens? Incontinence pad becomes waterproof because all that zinc goes onto the incontinence pad. And then it shoots up the back or down the front, up the middle, everywhere. So even if this had a lesion on it, even if the skin was broken, that's an incontinence-associated dermatitis lesion. It's not a pressure injury. Okay? Doesn't matter. That doesn't mean you can't have a pressure injury amongst this, but you work your assessment skills for that. It can get interesting. Stage 2, superficial. Okay, superficial skin loss, but also a blister. But the blister that has clear serum in it, no blood or pus. To pop or not to pop, that is the question. If it's clear, we tend to not pop it because it's a sterile environment and it acts as a biological dressing. We open that up, you get all the bugs in there and nasty things happen. So we move on to stage 3, full thickness skin loss. Full thickness tissue loss, subcutaneous fat may be visible, but bone, tendon or muscle are not exposed. Slough may be present. There may be tunnelling and undermining. It's often mistaken for a stage 4. The key thing is it doesn't go through the fascia. If you don't know what fascia looks like, you may find it difficult to stage. So that's why it is key often to have a wound care expert available or someone who has seen fascia. So if you've seen fascia, you can generally readily identify it. Though fascia is different on different areas of the body, it appears different. It depends how much work the muscle tends to do. So, but often that will be staged as a 4, but it's not a 4, it's a stage 3. Stage 4 is big nasties. $64,500 to heal a stage 4 pressure injury in a public hospital. We had 68 stage 4 pressure injuries at St George last year, 11 of which deemed to be hospital acquired. $3.5 million at St George for pressure injuries. We were asked to drop $3 million from our budget by the state government last year, as every major hospital was. We don't have $3.5 million to spend on pressure injury. Do you have $3.5 million to spend on pressure injury? Depends how you look at it. Most people don't get their money's worth though, because they die. We don't heal these. Okay, occasionally we do, but most of the time we palliate and the patient will die. The new one, suspected deep tissue injury, depth unknown. This is where we get a purple or maroon discoloration of the skin. It could be a blood-filled blister or a pus-filled blister as well. So it's almost classic. Years ago we would have staged this as stage 1. But the blood in the broken capillaries and blood suggests that the pressure injury is deeper, because there's 2 models of pressure injury development. It can go from the top to the bottom, but it can also go from the bottom to the top and work its way out. And that's where the big nasties come from. Or a bum like this. Often around these suspected deep tissue injuries, you'll see lots of little stage 1s as well, and you'll get these odd purple ones popping up. Unstageable, where we've got full thickness tissue loss, including eschar or slough. Okay. So big nasties like this. In the past, we'd automatically call this a stage 4, wouldn't we? But do you know what's underneath that black tissue? Sometimes when that black tissue comes off, it's lovely and pink and healthy, isn't it? Other times it's to the bone. We don't know. We don't know, we don't want to guess. So we call it unstageable. Okay. Matt's tip, if it smells before you see it, it's going to be deep. Okay? So if you can smell that before you see it, I guarantee you it's to the bone. If you've not got much of an odour off it, it may not be. But always beware of the wounds you can smell before you see. So this is one of those ones where the depth underneath it is quite superficial. Why? Because this was a blister. Blister skin is avascular, so what's going to happen to avascular skin? It's going to die and turn black and go over the wound and again act as a biological dressing. Now there's arguments to and fro. Should you debride necrotic tissue? It's case by case, I would have to say, because if we're not going to sharp debride this, so how are we going to get rid of it? Generally gels, say solicite gels and things. So we're going to turn that to mashed potato and it's going to smell. Is that better for the patient? Yes or no? It's case by case scenario for that. If HETI's available to you, there's a number of online HETI modules. All free. Even I have to do the pressure injury module, which is a pain in my backside, I can tell you, since I wrote it with the guys. And that's it. Thank you very much, everybody.